So it's a pleasure to have with us Dr. Kira Radinsky, who is the chairperson and CTO of Diagnostic Robotics, and Uri Bettesh, who is the founder and CEO of Datos.
Thank you.
We want to cover with you, as Ran mentioned, that the present is exciting. How innovation is entering the clinics, the hospital, and changing the way that we deliver caregiving at this time. So Kira, let's start with you. You have started an exciting company that changed the clinical triage. Could you share with us a little bit about what the company is doing and how it's becoming more relevant now at the Corona time?
So we as a company started to address healthcare loads starting from inside emergency departments. We had access to approximately 76 million visits inside emergency departments and primary care clinics. And we built an AI system that can read all of this information and then try to predict, based on answers to clinical questions, what is the probability of sending a patient to a certain diagnostic test, how urgent they are, and even reaching differential diagnosis. The concept initially was creating workflows to automate the 75% of the time of the doctor, which is not dedicated to the face-to-face meeting. We then realized that 30 to 70% of ED visits could have been handled in primary care. So we took our clinical triage system, this time for primary care, to start help navigating the patient to the correct location.
So currently in the Corona time, when many of the patients would not come to the point of care, would you take your system of the clinical triage and make it a telehealth solution?
So telehealth is just one way of talking to a doctor. But I think to actually nail this pandemic, you have to automate much more. You really need to realize whether this person needs to see a telehealth, should they be inside a hospital, or even be at home. So we started monitoring all of the population of Israel, large states in India, and even in the state of Rhode Island, all of the population, monitoring them, understanding what is their probability of having COVID based on their clinical triaging, and based on this creating epidemiological maps, explaining how the pandemic is going to look like in a few weeks from now. We then took the second step. How can we navigate them? We had access to billions of historical visits, and we predicted out of all of these patients who, if they have COVID, will deteriorate and needs to go to the hospital, and which can stay even at home. All of this helped navigate a lot of the care management protocols.
So that takes us actually to Datos and your exciting solution for the COVID-19 time, when many of us had to take the decision, if found to have COVID-19, whether we would go to the hospital or stay at home. And I understand that your solution played a significant role in the ability to have remote care automation.
So Datos is a remote care automation platform. Basically, we move care from the hospitals and the HMOs back to the home. And when the pandemic started, we worked with Clalit Health Services and the Ministry of Health here in Israel. And we put together a protocol for home hospitalization, home monitoring, to basically achieve two things. One is to protect the hospitals from the positive COVID-19 patients. And the other one is to provide care remotely to a large scale of population. And basically what the system does is we inject the protocol of the Ministry of Health into the system, and the system manages the patients automatically and provide a scoring, based on the scoring algorithm, provide a score for each one of the patients. And based on that, the physicians, the GPs, the nurses knows who to point to contact first.
Could I learn a little bit from the experience with Clalit, which I understand is now offering it to all of its patients in the home hospitalization? What lessons did you learn from this experience with Clalit at the COVID-19 time?
You know, it's very interesting because before the COVID-19, it was what we did. We provided a patient journey that basically we opt in. You had the ability to opt into that journey or to go back to the traditional care. Here in the COVID-19, there is no option. And I need to cope with Orthodox Jews. I need to cope with people that don't have smartphones or people elderly that don't know how to operate a mobile app or to go through a registration process. So we basically opened the platform, including text messages, emails, IVR, interactive voice response, in addition to the Datos app and all other things that we already do, like videos, integration to devices, data cleansing, and so forth.
Kira, I know that you as well in Israel now both did with Clalita project and with other care providers. What experience that you have with the doctors or the physicians in how they handle the data or handle the recommendations brought by the clinical triage or the automated software that you installed?
So our system was mainly predicting where COVID is going to spread. So instead of doing geo-tracking like many countries, which violates privacy, here on an anonymous basis, we created hotspots geographically around where COVID is right now. So on a daily basis, all of the HMOs and the Ministry of Health have been receiving a report telling them where COVID is right now, but most importantly, how it's going to spread. It actually started a lot of automation around this part as well, because you know where to send the COVID tests, you know where there's going to be loads. But this was perfect in the first wave. What happened after the first wave was very interesting. Less and less people started filling in the questionnaires because we were in this euphoria that everything is wonderful. And this is where we understood, just as mentioned here, is that you need some compliance from your patients to actually make this work. So in several countries in the world, they actually started making people do this, or at least making it harder not to do it. You want to go to work today, you have to fill it in, just like we're doing here in schools. You want to schedule an appointment with your doctor, you have to fill it in. And Israel will also realize that just keeping this anonymized is not serving all of the potential of those systems. Eventually, triage is something that is mapped to a person. But if we know who the person is, the company itself doesn't know who the person is, but the doctor should, because then they can call the person, they can treat them, and maybe stop the pandemic. Every 3 days that you take out of the time that these people just go outside, you've prevented a lot of the pandemic spread.
Oh, that's fascinating outcome.
I do have another we also worked in the US in quite many organizations. It's so different than what happens here in Israel. We have one accident in the US where a college implement our solution, and if you are not answering the survey, the symptom surveys, you are not allowed to access the Wi-Fi. So that's smart, right?
That's a motivation.
That's what we call nudge. Right? It's a very simple nudge.
That's an effective nudge.
It is a very effective nudge. Which I want to touch another point, Uri, actually, about something that you've said. You know, people sometimes think that the solution to getting innovation on the ground is to make it more sophisticated. But I think that it's some of the innovation that we put in practice, we did the exact opposite. So when we saw that patients do not find it trivial enough to get their, for instance, pulse oximeters connected with their devices, what was done was something very simple, right? We told them instead of doing a complex thing, just put in the numbers into the software in the most simple way, and this frugal innovation made it work. Is that correct?
Absolutely, and I think that it's all from a perspective. When you design a solution, we have to design it from the perspective of the users. And if for me to do pairing is very easy, but not for all the people in the society. But also when we think about scalability, right? In the COVID-19, you have to support a large scale of patients. Now, if I'm going to send connected devices, I need to get them back. I need to sanitize them. They cost a lot of money. So the simplest solution usually is the best.
So here in the same approach, some people really could not use online surveys. And this is where IVR comes in, right? So was IVR really important for specific subpopulations?
That's super interesting. So there's certain populations, like the Orthodox population, that they just don't answer surveys that you send them over text messages, right? So we identified those locations and had IVR call them. In certain populations, we've seen that the information coming from the digital form is very similar to the answers to the IVR, so we stopped doing the more expensive ones. But the concept is, no matter how you get the data, just get the data, and then analyze this.
I think that, you know, fascinating, understanding of the dynamic between the patients and the digital system, understanding about UI, the economics, behavioral economics. I think we could go forever. Unfortunately, we have to bring it to the end, the panel, but we would love to continue this conversation. Thank you so much.
Thank you.
Thank you once again.